We are a network of learning disability nurses working with people with learning disabilities and autism in acute hospital settings. This short film is to help our busy colleagues in A&E departments deliver the best care to people with learning disabilities. All the advice given in this film is underpinned by good practice guidance. The evidence tells us there's a real concern about the premature death of people with learning disabilities. We know that if you're a woman with a learning disability, you're more likely to die 20 years earlier. If you're a man, you're more likely to die 13 years earlier. We know that the number of people with learning disabilities in the population is increasing. And we also know that people with learning disabilities who also have complex comorbidities is also on the increase. So having a good understanding of what can go wrong and how to prevent it is what we want to show you.
I'm Danny, I'm 33 and this is my story. When I attended A&E, I saw the doctor and it was quite noisy, busy in A&E. I said, okay, I've got a learning disability, I've got dyspraxia with autism. And he said, okay, so how does it affect you? And I told him that loud noise, sensory overload, and I said, please don't use medical jargon or sort of any sort of long words. I said, because I won't understand it, it'll just go over my head and I won't get what you're saying. I said, okay, well, I've got a fear of needles, fear of injections. He said, okay, that's fine. He took me into one of the side rooms and I was able to wait there, and he said, right, I will come back and check on you from time to time, make sure you're okay. And he did just that. He was calm, he was talking to me slowly, he was making sure that I understood, and he said, right, is there any questions? He sort of related to me on my level. When he took the time, I was able to sort of get out exactly what was wrong with me. This is a hospital passport. This is what individuals with a learning disability are encouraged to have on them. It tells the doctors or the nurses or other clinicians exactly what is usual for that individual. Some individuals with a learning disability won't be able to accurately describe what's wrong with them. But if they have this on them and they show this to the doctor, they can see what their medical history is, they can see what their allergies are. Make sure that if the patient and the individual has got one of these, that you look at it and you read it and you sort of use it, because it could really make all the difference in getting to know that patient really well and having and the patient being able to really open up to you.
My name is Samina Hassan and my son is 19 years old. He's got autism and he's got learning disabilities. He's very challenging. He needs a lot of space. He's always on a go. He likes to walk all the time. It's really difficult for other people to understand his needs, especially when you are in a public place, because a lot of people don't know why is he making so much noise, why is he banging, why is he screaming. So things can be quite awkward sometimes. We were in the hospital because my son, we were in A&E all night and the doctors were suspecting sepsis. The doctors could not take any observation because of his challenging behavior. I advised that he needs to be put to sleep so that they can take all the observations, but that was not done. And we were in the department all night, and in the morning we just went home and nothing was done. It fills me with great anxiety. I think, a lot of times I think, do I really need to bring him here? And I'm worried that many doctors and nurses don't have a lot of experience with people with severe autism and learning disabilities.
Saida came to the emergency department with her carers, presenting with what appeared to be chest pain, shortness of breath and episodes of vomiting. Saida was a 51-year-old lady with a diagnosis of Down syndrome. She had good conversational skills and was able to express her needs. Initially, a pulmonary embolism was suspected. Saida's carers left and she was moved to a side room. Overnight, Saida was spiking her temperature, she had a low blood pressure and she was having more episodes of vomiting. Saida also had a large loose bowel movement that morning. The morning staff recognised that Saida was deteriorating and she appeared to be in significant abdominal pain. As Saida was becoming unresponsive, a peri-arrest call was put out and she was moved to the resus department. Shortly after being moved to the department, Saida had a cardiac arrest. Saida was diagnosed with meningococcal septicemia. The focus was placed on the pulmonary embolism, while Saida had a range of other symptoms. This delayed the treatment that she needed. We relied on Saida to tell us where she was experiencing pain, and we took this at face value. People with learning disabilities frequently find difficulty in expressing symptoms accurately. It is clear that Saida would have had a number of other symptoms that she was not able to communicate. There was no information recorded or shared about Saida's usual presentation, and there was no hospital passport. Staff did not respond to the fact that Saida was not communicating and appeared to be confused, which was very unusual for her. Saida did not have an advocate or a carer with her, and we know this places people with learning disabilities at higher risk of something going wrong. At the time of cardiac arrest, a question was asked about Saida's quality of life. Saida was a valued member of her family and community, and she enjoyed a very active life.
Ali attended the emergency department alone after experiencing stomach pain. Ali has mild learning disabilities and communicates verbally. Following investigations, nothing significant was found, and he was sent home with paracetamol for pain relief. 2 weeks later, Ali was visited at home by a healthcare professional who noticed alongside the paracetamol he had been taking cocodamol. The cocodamol had been prescribed for dental pain 2 days before his attendance at the emergency department. A learning disability is not always evident. If you suspect that your patient has a learning disability, please check their health records for a learning disability flag. People with mild learning disabilities often come across as very able. However, they will still have significant gaps in their knowledge and understanding. Get into the habit of checking understanding by asking your patient, tell me in your own words what we have just spoken about. Providing easy read discharge summary information can enable the patient to share this with their family or carers and someone who knows them well. When prescribing new medication for a patient with a learning disability, please check their current prescription, and you can do this by contacting the GP or family member, a carer that knows them well, or even the community learning disability team. If a patient with a learning disability attends the department alone, we need to gather some collateral information. We can do this by contacting the family, a carer, or maybe the community learning disability team. If you have concerns about a patient with a learning disability, please consider contacting the Learning Disability Liaison Nurse team for support.
When you first meet someone with a learning disability in the A&E department, it is easy to attribute their presentation to the learning disability and not an underlying physical health problem. We know this as diagnostic overshadowing. Diagnostic overshadowing is one of the biggest reasons that things go wrong for people with learning disabilities. Our attitudes to people with learning disabilities are shaped by our culture and direct experience and can easily influence our care and treatment. Some of the examples we see are describing a patient as bedbound. Very few people with learning disabilities are bedbound unless they're seriously unwell. Never making any real attempt to communicate with the person themselves, assuming that they can't communicate at all. Describing or ascribing a person's challenging behaviour to their autism or learning disability or a mental health problem when in fact there's an underlying physical health problem. When we suggest a patient is agitated when in fact they're actually communicating that they're in pain. From our collective experience as learning disability nurses, there's a couple of observations we'd like to share. The first is people with learning disabilities and autism often present very atypically. So it's important to keep an open mind about diagnosis and also recognise there's often more than one diagnosis. Secondly, some people with learning disabilities and autism often present with high pain thresholds. This might mean that we miss fractures and some serious illnesses. So in summary, when we meet a person with a learning disability, we need to think flagging. Check there's a flag on the system because there might be really important comments attached to it. Think about the hospital passport. Ask for it, read it, and consider how we then need to deliver care and treatment. Consider our communication. Always talk to the patient first. Then consider visual aids, use of objects. Think about short, simple sentences, and always check understanding. Always consider mental capacity and involve others as appropriate. And lastly, think about the reasonable adjustments that we need to apply. Treating somebody really quickly if they can't wait. Allowing them to sit in a quiet space away from the busy waiting area. If a patient comes in with any trauma or injury, carry out a secondary survey and always consider the need for a senior review. Make sure we involve family and carers. If you find you're unable to do the basic observations and standard diagnostic tests, speak to the family and carers about how best that might be achieved. For a small number of people, sedation may be the only way that we can carry out the necessary tests and investigations that leads to a diagnosis and appropriate treatment.
If there's anything in this film you would like more information about or would like to discuss, please contact your Learning Disability Liaison Nurse team. Thank you.